Okay, now we're going to open up the floor to questions. So a few hands already going up. Just, if you have your question, specify whether you want one person to answer or if you want the whole panel to answer or random. Got a question in the back.
For Dr. De Silva. She was speaking about glutamate damaging the brain and things in the brain. So then would you recommend that people who have NMO and stuff not take glutamine supplements or MSG?
I think that that's a common question that's asked, and I think that we're talking about perhaps two different mechanisms. And as far as I know, there hasn't been any studies looking at monosodium glutamate causing excitotoxic mechanisms, and maybe if there's anyone else who's been involved in that. So I don't necessarily think that, although we haven't really looked at those types of mechanisms in the brain. I think that it's something to consider, and I'm not real sure about that. I'll leave it at that.
What about the L-glutamine supplements that a lot of people take, like if they're working out, exercising?
I'm not exactly sure how those are metabolized, and I'm not sure that they cross the blood-brain barrier. So if someone else has any information on that as far as exercise and those types of supplements and metabolism, perhaps they may know more.
Questions over here?
Hello, this question is for Dr. Katz and Dr. Healy. Regarding the two trials you were speaking of, will they be taking place in the United Kingdom as well?
I can certainly
So, I'm sorry. Our study actually is a global study and is running now all around the world. We have sites in South America, in United States, in Canada, in Europe, Western Europe, Eastern Europe, Japan, Singapore, Korea, Australia, New Zealand, South Africa.
And Texas?
We eliminated Texas from obvious reasons. So it's a global study, and we involve about, I think it's right now we have about 95 sites all around the world. We have, maybe you heard about it or not, but we have our study compared to all the other study is a pure placebo. In other words, we randomize 1 to 3. One getting placebo, nothing else, and the other 3 get the drug. This created a lot of discussion in different countries. Eventually, most countries accepted it. England was one of the countries that the investigators, they were a little bit reluctant about it. I don't know if you know Jackie Pallas from London.
Yeah.
I visited with her a few months ago. She actually in a process of looking at the study, and she thinks she's going to be part of the study. So I think if this will happen, England will be also part of the study. Right now, England specifically is not, but we hope in the next few months it's going to change.
Okay, brilliant. Thank you.
Certainly on behalf of Optica, our clinical trial in NMO, since it's a phase 1 study, will be restricted to North America in the first instance. Obviously, as we start to see positive activity and we build the safety program, then we'd want to obviously look outside North America as an opportunity to provide our therapy to a global population. I should say that although the NMO program itself is in this preclinical early phase 1 program, we already are in a phase 2B program in secondary progressive multiple sclerosis, a related autoimmune disease, if you like. That's a 35-site clinical trial, 180 patients that's currently ongoing that reports the data then next year. So although we're relatively new to the NMO world, we have quite a track record already with this type of autologous T-cell therapy for the treatment of autoimmunity.
Next question.
Dr. Levy and Dr. Greenberg had brought up the fact earlier that we have, patients that are going to doctors and getting diagnosed certain ways, and then, of course, then they get, treatment certain ways, but it's turning out to be incorrect. So the question is there some way to get the word out to all the neuro doctors out there that giving MS drugs to patients that aren't MS is while it may not be killing your patients, is certainly doing more harm than good. At least that's the takeaway that I got from y'all's presentation, that it's not good to be taking MS drugs if you're TM or NMO, right?
That is very true. I'll just speak for the panel here that we've only begun to understand how these mechanisms work and why the drugs in MS are harmful in NMO. So the first thing we want to do is be certain that we're providing the right message. And then in parallel, we're trying to get the word out through educational seminars, like what are called continuing medical education courses, publications, through the Academy of Neurology, to really spread the message is what you're saying, that these drugs for MS can be harmful for NMO. Question up front?
You all spoke about NMO. I think many of us here are TM people, if you will. Are your trials and the drugs you will hopefully come out with relevant for TM people as well?
Actually, can I point this?
I think, I think one of the things you see almost in any drug that's being approved for one disease, that people start to use it in other diseases and see what the effect is. This is something that naturally happened because physicians try to use new drugs. If I can talk about the B cell, B cells function probably has important function in MS, probably in NMO. I don't know specifically to tell you about transverse myelitis, or maybe without the transverse, as we learned today. But it may be also because it's all, if you're all talking about immune mechanism, the B cells and the T cells are all important component of this system. So by the virtue of showing effect in one autoimmune disease, you may probably can think that it may help in others. So I'm sure people will try to do that. So remain to be seen.
Have any of the companies up here considered drug use in the acute TM period for patients who don't have a diagnosis of NMO, but they come in with transverse myelitis? Maybe your drug would be useful in that setting?
So from the Alexian perspective, the focus has been NMO. And, if I anchor that just in the opening session last evening for those who were able to make it, we heard a little bit about, it's important to be able to identify the target, to really understand what is at the root cause of the disease. And so if I take eculizumab, we know it blocks the complement system. That's the first thing. And the second thing is we believe it's strongly implicated in the manifestations, the presentation, the clinical consequences of NMO. And so that has brought us down the path for undertaking the clinical trial in NMO. So that has been the focus, not just to share a little bit of the background and the thinking and the rationale. But at this point in time, no, we haven't considered, for example, the acute TM setting that Mike mentioned.
Yeah, so far for Chugai, it's the same. Our focus has been NMO.
As you remember, our strategy for Optica is to selectively target the immune response onto the antigen-specific T cells causing damage. So the key phrase there is antigen-specific. At this time, we don't know what the target antigens are that are being recognized in the TM lesion. Obviously, NMO has that highlight of the aquaporin 4 or maybe MOG in some individual patients. And so until some knowledge base is available to at least our technology on the basis of antigen specificity, it becomes quite difficult to port it to the TM environment. But having said that, we are working on a potential alternative platform, still generating a T-cell therapeutic that may still be able to tackle autoimmune diseases where target antigens are not known, but that's still very early preclinical.
And if I just might add, I think too, we're talking about basic science research. I think something that is very important for transverse myelitis is for us to have more human samples to study, meaning CSF, serum cytokines, these types of markers where we can understand more of the disease pathology as well as the tissue itself and understanding the immune cell infiltration. I think that this has happened in MS and in somewhat happened in NMO with having these markers, and we still need to push forward on that. And I think that'll also help us on the basic science level drive research more on a better understanding of how this happens. But I think that there are two key mechanisms that we can start looking at, and that is initial immune cell infiltration and then CNS protection. And those obviously do speak to the other autoimmune diseases as well.
More questions up here?
I'm not very skilled in the immune system, but I guess I was thinking that the immune response was not necessarily cell-specific, that our bodies produce an immune response. I'm not very sure about the immune response and its specificity. Like, are these immune responses specific to the spinal cord and to the central nervous system? Is there a different T cell or B cell in the brain versus the spinal cord? So that I understand that you're attacking that antigen that's specific to NMO, but it makes sense to me if the immune response is general. Is it specific to the system or specific to the cell?
So this is a very good question. And actually, we usually look at the immune system to have two types of response. One is not specific. And this, if you get a cut and you start to get red and a little bit pus, this is kind of the immune system respond to some damage or some bacteria going in, and it's not specific, but it's kind of inflammation, a general inflammation process. However, most of the immune system is highly specified. It's very smart. It's like you develop special, you have the Navy SEALs, you have the Delta Forces, you have everyone is specified in certain thing. This is the immune system. And it's going after not specifically about the brain or spinal cord or the liver or the kidney or the lung. It's going after specific molecule or specific trigger so for example, any virus go in is a different type of virus. So the immune system is launching an attack on this specific virus and not any other viruses or any other thing. So it's very specific and it's very smart. And the way they're doing it, there's like recognition phase when the foreign thing comes in, or if from whatever reason they start to look at our own tissue as foreign, let's say in autoimmune diseases, then there's recognition of this foreign thing here, and then there's a trigger to develop B cells and T cells that are specifically going only after this foreign entity. And this is very fascinating. It's very unique.
And basically, if I could add, what we need in TM is a quantum leap to identify the immune target in TM. We had that from our Mayo colleagues in 2004. They found the target in Neuromyelitis optica, and now we have 3 or 4 trials. So what we need is the target in TM. I saw a hand up.
Okay. What's that? Wait for the mic. I will. Thank you. Okay. From my reading and from my own personal experience and from what my physician told me, they say I have, mild transverse myelitis. I'm pretty much recovered. But they say now, because of a lot of my blood work, like my rheumatoid factors through the roof, that I have an autoimmune disease now. To me, it seems like contradictory that if you're improved, that you now have an autoimmune disease if you're not getting reoccurrences. Can you help me with that one?
I think one of the small group sessions will deal with those kind of questions, but the summary is that these autoimmune diseases come and go. They attack and they go away, and they attack and they go away. And the markers may be there in your blood the whole time, so we may be able to detect those rheumatoid factors even while you're feeling well, but you may be susceptible to an attack in the future. That's kind of the overall thinking. Yeah.
How far away are we from identifying the immune markers for TM in terms of research?
It's been discussed so many times. When I first started working in this area, I remember Sandy Siegel on the phone with Doug saying, do we have a target yet? Do we have a target yet? We've been looking for it for a long time, blood, spinal fluid, tissue. And that echoes what Dr. De Silva was saying, is we need these samples to be able to look for these biomarkers. I don't know how many it took to find the one in NMO, how many samples they had to collect, but I'm sure it was a lot.
So how many would you actually need? I mean, based on what they did for NMO, would you say like, I don't know, 100,000 people, for example?
I'm actually gonna, if Brian, is it okay if I pick on you, ask you this question? The question is, how many samples do you think we need from TM to really be able to identify, say if there were an antibody marker, how many would you need to be able to identify it?
Well, if we look at the experience in neuromyelitis optica, I could just tell you the history of that. I had been studying it clinically, and at Mayo Clinic, I have a collaborator, Dr. Van de Lennen, who discovered the antibody, but she became interested because when I gave a lecture about this, I said, you know, a lot of patients with this condition have other antibodies. I think more or less is the question we heard in the front row. We saw rheumatoid arthritis antibodies and lupus antibodies and a variety of antibodies, and we don't usually see this in MS. And so she said, maybe this is kind of a special variant of multiple sclerosis. And she said, could you send me some samples? Well, as it turned out, after I had sent her 3 samples, she said, you know, in 2 out of the 3, I was able to detect an antibody pattern. And well, that's only 2 patients with this pattern. But then the incredible thing, of course, she had this lab that got samples from around the world. She'd had tens of thousands, if not 100,000 samples. And she said, you know, I have seen this pattern before. She pulled out a scrapbook and she said, in these samples, and she had a number of these samples stored away. She was able to take out the blood, show that this was the same sample that she'd seen in the neuromyelitis optica patients. And I said, well, what history did those patients have? And she said, well, you know, they came from all over the world. But I contacted those physicians. And at that time, she wasn't getting samples from patients with transverse myelitis and optic neuritis. She was mainly interested in other conditions. So, you know, it would have been unlikely that those would have showed up in her lab. But as it turned out, when I called those physicians, every single one of those patients, we were able to get a clinical history in 12 of these samples. All of them had optic neuritis and myelitis. So, make a long story short, it didn't take very many samples. But I think the key thing was, and I didn't discover the antibody, but I guess my biggest contribution, and Dr. Wingerchuk, who worked with me, he hadn't been working with me at that time, but was that we recognized a clinical picture that was very distinctive and homogeneous, as it turned out. And I think that's the problem with transverse myelitis, because transverse myelitis isn't a disease in the same sense as neuromyelitis optica is. It's a syndrome. It's a collection of symptoms and signs. Some have optic neuritis, some have MS, some have strokes of the spinal cord, some have this, some have that. So I think if we had one disease, transverse myelitis, and if there were an antibody, we could find it with relatively few patients. But I think the problem is that we have to change this concept of transverse myelitis being a disease transverse myelitis. It is a syndrome, and our big job is to parse out these various groups, as we did with neuromyelitis optica, into other groups. Maybe there will be other antibodies for transverse myelitis, but I'd be very surprised if there was a single target for all the rest of transverse myelitis. I think we're going to be dealing with a number of different groups. I don't think it's necessarily an infinite number of different groups, but, you know, of the patients we see, I think we come up with so many different diagnoses than we did in the past. So a long-winded answer, but hopefully that was helpful.
Question in the middle.
Hi. Virus versus genetics. I was when I first started studying about this, I was under the impression that this was probably a genetic thing, genetic mutation of some sort. But now I'm starting to get a lot of stuff in my head to make me believe this is virus related. So what I'm confused about is, if it's virus related, how is it that we're able to pass it along to our siblings and our kids? Is it like chickenpox, where it's just going to pass through the bone marrow and through the genes or whatever? DNA, sorry. But the point is that how does that all relate, basically?
I think the conventional wisdom is that there is a genetic predisposition. So you inherited something from your parents that made you susceptible to developing the disease, the transverse myelitis. But then there had to be an environmental trigger. It may be an infection, a virus, maybe a toxic compound. We don't really know. But it triggered your immune system to then attack your spinal cord. That's still the conventional wisdom. If there are others here who have ideas about how this happens and the contribution of genetics, open it up to the panel. Although I'm getting a look from Dr. Greenberg here. Oh, please, Dr. Banwell.
I mean, I think there's precedent for the concept of a very clear genetic abnormality and a viral trigger. So in kids, we see very rare conditions called hemophagocytic lymphohistiocytosis. And yes, I practiced that. And these are definitely genetic disorders, and they're abnormalities that make patients very prone to Epstein-Barr virus infection as infants, typically, and it leads to a very, very devastating immune response that is directed against multiple organs and sometimes the brain. And so that's just an example of that interplay. If you were never exposed to Epstein-Barr virus and you had one of these genetic conditions, you might never get sick. And so that's one example. There's another disease of an exceedingly rare disease with a mutation in a protein called RANBP2. And in those patients, if they get exposed to a particular types of infections, they get a serious brain illness. But if they don't get the infection, they don't. So, in those examples, I think it sets the precedent that there is an interplay between how your immune system is developed genetically, how it responds to challenge, and that challenge might even be important at the age at which it's exposed. So there are, certain infections that can cause serious illness in genetically predisposed people if you get sick as a child, but not if you get the infection as an adult. And conversely, you can also have situations where if you get the infection when your immune system is less mature, you may not get sick in the way that an adult would with the same infection. So it's complicated, and I think that there could be an interaction between both.
So with that in mind, I think we're moving into the Q&A session just by naturally. And so I think what I want to do is thank our panelists for this section of things. We really appreciate it. And then I'm not going to call you by name because you know who you are, who's supposed to come up and be on the panel. But if I don't see you moving this direction, I will call you out by name. Brian's coming, Brenda's coming, Terry's coming, Michael's here, Ming is coming. Dr. Harder, are you on this panel? Great, come on down. Dr. Becker, good. I think we're going to have everyone. So while the panelists are coming down, I get to introduce somebody who is near and dear to the UT Southwestern Heart. So first off, actually, everybody here should be a member of the Transverse Myelitis Association. So presumably you are. If you're not, please sign up, log in. There is no fee to sign up. It is free of charge. But it's an incredible advocacy organization that does a lot of things, and the more membership they have, the better they can advocate on behalf of the community. One of the things the TMA has done is raised funds purely through donations from you and your friends and family for a lot of different things: symposium, camps, research endeavors, patient advocacy, patient ambassador programs. But one of the most critical things they have done is raise funds for the Jim Lubin Fellowship in Rare Autoimmune Disorders. So what is a fellowship and why is it important? So in order to become a physician in the United States, you go to college. You then do 4 years of medical school, and then you do a residency that will go anywhere from between 3 and 7 years, depending on the specialty you pick, and then you can go on, if you choose, to do a fellowship. So a cardiologist is somebody who's done an internal medicine residency and then went on to do a cardiology fellowship. There are fellowships in all sorts of things, usually the common diseases. Up until the Jim Lubin Fellowship, there were 0 dedicated fellowship options for these autoimmune diseases of the central nervous system. There were fellowships galore for multiple sclerosis, but none for somebody who had completed their neurology training who wanted to focus on these conditions. So when I did my fellowship, it was a joint research fellowship in virology, but it was also just do what Doug tells you. It wasn't very organized. I mean, in the sense of having a curriculum other than whatever Doug tells you. And so through the TMA in their work, the Jim Lubin Fellowship was initiated, and the first recipient of that fellowship ever was Dr. Alan Disseminated, who was is a pediatric neurologist by training. Did his residency here at UT Southwestern and Children's, and then stayed on. He was under the influence of something when he signed on to do his fellowship here with myself and our team of neuroimmunologists. And the fellowship was an absolute success in the sense that Alan left. And it's rare for us to describe that as a success. But the reason it was is because the goal is to spread out the expertise around the country. How many people here live in a city where you would consider that there is a TM dedicated center or TM expert in your community? So the minority of hands. And wouldn't it be great to be able to go down the street to a neurologist who gets it, who knows it? And the idea of the fellowship is to do just that, get people trained and spread them out. So up until this past year, there was not a TM center in Ohio, and now there is in Cincinnati. So Dr. Disseminated is there seeing both pediatric and adult patients. He has the unenviable task of moderating this motley crew of clinicians and scientists, so I wish him much luck. Feel free to bombard with questions. No question is too silly. Do not be shy. And we'll see how many we can get through before we get to lunch. So, Dr. Disseminated.
I just want to say thank you to the TMA for all of their support and for the opportunity and for the invitation here. It's been a very good experience for me, and I think for the other providers up here. So I'm going to go through, and by all means, if there are any other questions as we're going through this, because I have several here in front of me, if there are any other questions, that, and also specifically if you wanted a certain or specific provider to answer the question, please designate that. Then either flag Paula or Sam that are around, and they'll come and grab the questions from you. So I have a few questions here, and I'm just going to start. We'll start with Dr. Becker. So I have one question. I already have the mic. Very good. One question for Dr. Becker is, when or where, I added that, will electrical stimulation be widely used in neuro rehab?
Well, so the first question is pretty easy. The second one, where? So there are a couple of places in the States now that use electrical stimulation. The one where I trained was at the Kennedy Krieger Institute in Baltimore, and then our center, the International Neuro Rehabilitation Institute in Baltimore. But then there are FES or electrical stimulation places all across the country. They're just really hard to find. So all the therapists, even across the world, I'm sure I know people in the UK who do that. All the therapists all receive some training in the use of functional electrical stimulation. It's just many of them don't get the specific training that they say, this is the way you use this for an injury to the spinal cord from either TM or traumatic spinal cord injury. So what we're trying to do, we're trying to spread the word, and that's really hard, but it has helped. So we started this process in the early 2000s, late 90s. And I remember when we had the first paper we were trying to publish about the use, what happens in the spinal cord with electrical stimulation. People looked at us like we were crazy, and it took almost till 2010 to get one of these big papers out for that. But since then, it has spread. And I'm sure anybody who has been following the group around Susan Harkimer in Kentucky, in Louisville, Kentucky, anybody? This was big on the news a couple years ago when she used epidural stimulation to help people regain standing and sometimes even walking. It was big on CNN. So there's a group there. There's Reggie Eckerton's group out in California, and Dr. Greenberg's group up here is trying to get similar activity-based programs going. So overall, we're trying to spread the word. And it's not just us. I mean, it's multiple people. And I think it has gotten much more traction than it used to when I started this. But what helps is if you go to a center that uses this technology, or find a therapist locally that has used it, get trained on it, and then take it home with you and teach your local therapists. Most of the therapists are actually very eager to learn. So we see this all the time, that we have people come to us, we give you a home program, teach you which equipment to use and how to use it, and it's all printed and written out. And you can take it home and you find a therapist that you click with. And then you say, okay, can you please help me follow this? And they want to learn. Sometimes people, if they come from outside the States, they bring their own therapists to us. We teach them during that time and send them home with it. And then you can see that we sort of put these little seedlings down and then start spreading. In London is the group around Farshide, Bondarenko, yes. She has a group there and does a very good job sort of trying to spread this there. So I think it takes time. That was the second question, right? We know where, but I mean, it's a paradigm shift. Many people were taught, especially in neurology, that it's static and there's nothing we can do. But I think overall things are changing.
Maybe an extension of that question for some of the other providers on the up here is, how have you counseled some of your patients that feel like they're having suboptimal rehabilitation in terms of strategies and engaging their therapists? Maybe one of the other providers might comment on how they counsel some of these patients to explore other rehabilitation options.
As a transplanted Canadian in the U.S., I can comment that access to any supportive services varies by country. Within a country, it varies by here state, in other parts regions, and then even within a region, it varies by access and expertise. So there is no one answer to that. I think the advocacy piece, and it puts a big burden on the family, as all of you in the room would know, is to, as you've been hearing, get as much training as you as a family can so that you can enable the rehab to extend more at home with more confidence. And to measure change so that you can see when something is working and importantly see when it isn't, so that you can go back to the core therapy sessions and advocate for yourself or your child or your loved one. This strategy seems to be working, this doesn't. I think engaging your physician and educating your physician if they don't know how to advocate for you. One piece of advice I give my families is that if you really passionately feel a particular center is better than others and there's a reason why that seems to be a good place, help us write the letter. Get some information about the center if you can, and help us put in text that will get your insurance to approve why you need that particular strategy. Write letters with your physician. One of the biggest challenges we get as clinicians, it's not that we don't want to advocate for our patients, but you can only imagine what the end of the workday looks like after you've seen a whole clinic full of patients. You have notes to write, you have doctors to call, you have labs to check, you have MRIs to review, and a 3-page letter effectively advocating the best possible care for your patient is another challenge. And we would do a better job if you came with a draft, or better yet, electronic draft to us to say, these are the things that I know about the center. We will take responsibility, of course, for our own signature and making sure what we write is correct. But do it with your team. Write together, and it's more effective.
All right, very good. So we're going to move right along here. This is a kind of a general question for anybody who's willing to jump right in. Would an anti-inflammatory diet slash vitamins provide any benefit for TM patients? Does anybody want to jump right in?
Is that still for me? Yeah, okay. So we've studied vitamin D in pediatric patients with acquired demyelination quite carefully, and many other groups have too. If you look at serum vitamin D, which is 25-hydroxyvitamin D, which is what you measure in the blood, at the time of an acute demyelinating attack, whether that's transverse myelitis or a different presentation, it is considerably lower than it would be for age and gender-matched community controls, with the caveat that about 80% of people in climates where we have winter are vitamin D insufficient for most of the winter. So we're comparing patients to an already vitamin D insufficient community. So it is a common association. There are cell studies that show that your immune cells, for lack of a better word, get permission to be overactive in the context of a low vitamin D. So we do supplement our patients carefully with vitamin D. We do believe that there is a role for vitamin D potentially in reducing your likelihood of relapse, although that hasn't been proven. Certainly the reverse is an important statement, which is, to my knowledge, there is no health benefit of being vitamin D insufficient. It's not good for your bone health. It's not good for your future cancer risk. It's not good for your muscles. If you don't know this, and this is important for rehab, very low vitamin D values makes muscle weaker. And when you actually fix vitamin D insufficiency, patients can be stronger. So it's relevant not only for your immune system. So I think talking to your physician about your vitamin D values is important. And I'll say one more thing and then I'll stop talking. In MS and in potentially neuromyelitis optica, although I think it's better studied in multiple sclerosis, there is evidence that your vitamin D levels when you were a child influences your risk of multiple sclerosis as an adult. In twin studies, the vitamin D insufficient twin was more likely to be diagnosed with MS. And so for children of parents with an autoimmune disease, I would advocate that keeping your children vitamin D sufficient is not only in line with the health regulation recommendations from the American Academy of Pediatrics and the Canadian Pediatric Society and the UK Society and in every country I know of, but it may theoretically reduce their likelihood of developing an autoimmune disease later in life.
Okay, I'm going to extend that question because it's a question I've gotten a lot too, and it's a general question for the providers, is there are multiple books out there that you can get on Amazon right now that describe an anti-inflammatory diet. And would anyone care to comment about how they counsel the patients when, because they're hearing a lot about inflammation with TM, NMO, some people reference MS, of course. And so we have multiple popular books out there that tout an anti-inflammatory diet. And so the question is a lot of these individuals out here are hearing a lot about this, and how are they to put that in the context of all these things that are saying that certain foods are pro-inflammatory?
I'd like to comment on vitamins a little bit, and I will make a comment on the diet. So the other vitamin that is extremely important to take a look is vitamin B12. And actually, when we are in a school of medicine and we are training residents, we always tell our trainees is pay attention to the vitamin B12. Vitamin B12 is one of the ones that we need to investigate if there is any spinal cord disorder or any type of demyelinating disorder. So vitamin B12 is critical not only during the initial assessment of any myelopathy, but it's also important after the myelopathy, because any deficiency of vitamin B12 will impair any potential recovery or regenerative pathway in the body. So vitamin B12 is extremely important. I will caution you to the excessive use of multivitamins, and let me give you an example. When you take a look of the bottle of the multivitamins, you need to pay attention of the composition. There are some vitamins that may be toxic in high doses. Vitamin B6 is one of them, and actually vitamin B6 is occasionally associated with peripheral neuropathies. We occasionally have patients that come to us and say, oh, I have a lot of numbness and tingling, and we go and take a look of the medications, and we see that they are overusing vitamin B6, and that is one thing that probably need to be checked. I mean, I'm going to give my opinion on diets. It's eat well and healthy, that's it. I don't believe that there is any anti-inflammatory diet. Inflammation is a mechanism that our bodies use to respond to a challenge from X, Y, Z factor. And myelopathies and myelitis in general are produced in a setting of either a post-viral infection or autoimmune disorder or other type of setting. And in some patients, yes, there are autoimmune disorders that probably are going to be chronic. But our body is quite clever, so the potential for adaptation is fantastic. And I don't believe that you need specific diets, oils, or anything like that to supplement your diet. I think eat well with a good amount of vegetables and a good amount of proteins, and take a chance to talk with a dietitian. Dietitians are there for helping you to design what is the best for you. So there is no standard anti-inflammatory diet, I believe. And I think that you should talk with your provider, physician, and dietitians about the best avenues to deal with your diet.
Okay, we're going to move right along here. This question for Dr. Levy. Why do some MS medications make enema worse?
Well, we're learning more about that. And what we think is going on is that there is a different immune response that causes MS from the one that causes NMO. And the treatments for MS, what they try to do is change the immune response from the one that causes MS. And it happens to be that the one that they're changing it towards is maybe the one that causes NMO. That's the real basic oversimplification of what goes wrong when an NMO patient takes MS, is that we're changing the immune response from one that causes MS to one that causes NMO. So if you have NMO, you don't want to be on that drug. The drugs that treat NMO are generally suppressive. They don't change the immune response, they just suppress it. And that tends to be helpful for NMO particularly, and may also be helpful for MS. So I do get quite a few patients who have this sort of borderline diagnosis, or you have a lot of features of NMO, but some features of MS, we're not 100% sure. And what I often recommend is a treatment that suppresses the immune system, because we know that's helpful for NMO. We think that's pretty helpful for MS, especially with recent data. And so it may not be harmful, especially for those patients who have that sort of borderline diagnosis.
All right, very good. It's kind of a general question for the group. These are very, by the way, outstanding questions from the audience. How come some MRIs show TM, others do not? So I'm going to reword it. So a lesion negative MRI, but the patient clearly seems to have symptoms consistent with a myelopathy or problem with their spinal cord. Can any of the members on the panel talk about maybe some cases or some thoughts about this, other testing, et cetera?
Yes, that's a difficult question because each person is individual. I would say the first issue is the diagnosis of transverse myelitis correct or not? And we've heard conditions like Guillain-Barré can cause similar symptoms. Certainly the problem could be that the patient really has transverse myelitis and they were diagnosed with Guillain-Barré, but the converse can also be true. Some patients may be suspected of having transverse myelitis, but may have this disease of wire number 2 outside the spinal cord. Dr. Greenberg, I like that, wire number 2. So that can be an issue. Often it is technical factors as well. And you've seen some very nice pictures today with very clear pictures inside the spinal cord, but not every MRI is the same. Some that come on portable trucks that maybe have old software. Seeing inside the spinal cord is a tricky thing. And I've seen situations where MRIs have been so fuzzy, they've been uninterpretable. And it's possible that if you have an MRI on one of those machines, that a true lesion inside the spinal cord of transverse myelitis may be missed. It also depends on the timing. Some people who had an event a couple of months ago or a couple of weeks ago, and they've had steroids, and then they get an MRI when they see a neurologist. Maybe they were treated in a rural hospital and they didn't have access to MRI. There aren't too many hospitals or too many places where we can't get MRI these days, but it does come up, and the lesion may have disappeared. And in fact, there are situations now, in some places, MRIs can be done right out of the emergency room. If it's very early, the lesion may have been missed. I think there are other conditions of the brain that can sometimes be confused for transverse myelitis. Some conditions like degenerative diseases like progressive supranuclear palsy. Other conditions like stiff man syndrome, which is another kind of autoimmune condition that can cause muscle stiffness and be confused as spasticity. Occasionally those patients will get a label of transverse myelitis when they really have a different condition. So if I have a patient who I'm thinking transverse myelitis and I got a really good quality MRI scan and it's negative, it really makes me think again and say, do I have this right? is the diagnosis of transverse myelitis correct? I don't know, maybe some other people have other explanations why MRI might be negative.
I agree with all of those. The only other one I would add is when you take an MRI scan of the spine, it's typically done in segments. They don't take one photograph of the spine top to bottom. And so where one segment ends and the next segment begins, that area isn't well visualized, and sometimes it's right where the lesion is. So, and what needs to be done is what's called centering the MRI around where you think the lesion ought to be, not doing the standard, I'm going to image the top part of the spine, the middle, and the bottom in 3 standard blocks, which is what a regular MRI would do. So particularly commonly in my experience is that patients that have changes right in the middle of what's called the thoracic spine, so right in the dead center of the spine essentially, that can be an area that's poorly visualized on MRI scan unless you lift up that middle sequence and photograph using the MRI at its maximum capacity. So I frequently will send people back, even after a perfectly good-looking MRI, if that's where I think the lesion is, and ask them to change the way they take the picture. And we found a number of patients where that is indeed the problem. So it requires your neurologist to take a careful exam, as they ought to do always, but then don't accept a normal MRI just because it looks like it was done well. Make sure the MRI focused on the area specifically.
Yes, and I would like to add that as a part of the discussion from yesterday, there was, although no conclusions were made, but it was, the conclusions will be forthcoming, that the importance of a standardization of imaging for suspected myelopathy and acute or acquired myelopathy or myelitis is exceedingly important. We're going to move right along here. This is another general question for the group. Can being overheated, such as in the case of maybe an infection, or being overheated from other causes for a prolonged period of time, trigger a definite new immune-mediated relapse? Does anyone want to take it?
I'll take a stab at that one. What we think is going on when you're overheated is that the damage that was done previously is not compensating well. So you're feeling your old symptoms again. I don't think there's any evidence out there that heat triggers an immune response per se that could lead to another relapse. I think that it's more likely that the immune system is not involved when you're symptomatic from being overheated. Are there any other comments?
What about thoughts about infection provoked relapses?
Yeah, well, certainly we know in multiple sclerosis, and this goes back many years ago, there was a doctor who won an award for multiple sclerosis. His name was Dr. Sibley. He did a lot of work looking at correlating attacks of multiple sclerosis and viral infections, and there seemed to be a pretty clear correlation. That is, after getting a viral infection, you were at higher risk of having an attack. So I think the same likely is true in neuromyelitis optica. We certainly hear a lot of patients who get transverse myelitis, which is an immune-triggered disease, that they have a preceding viral infection. So I think these things can stimulate your immune system and cause true attacks. But some people who've had previous attacks of MS or transverse myelitis, who have injured nerves, will get fever when they get viral infections and get, as Dr. Levy mentioned, the electrical conduction just doesn't work as smoothly, and when the body's overheated, there's some breakdown in that electrical conduction, and they don't have an attack. So I think when there is this association with a virus infection, we shouldn't rule out that it is a true new attack with new inflammation, but it could be not a true attack. And those rules that Dr. Levy mentioned to you before that we think of, is it the same old symptoms that are worse, or are these new symptoms? Do the symptoms get better as soon as the fever is controlled within, say, 24, 48 hours, or do they progress and get worse and worse? Those are usually the rules that we think of when we're trying to sort this out. And occasionally we'll do an MRI if it's very clearly important to know whether there is new inflammation or not.
I just want to follow the other side of the heat and fever story, which is that patients that have had demyelination, as was being discussed, do experience more difficulty when they're overheated. It's also true that patients can have better function when they are a little cooler. And so for patients undergoing rehab strategies or exercise, being a little bit cooler and doing your exercise in a cooler room, even wearing a cooling vest, can make exercise more efficient. And so certainly in the MS literature, there is some quite nice studies that have come out of Dr. Kesselring's work showing that MS patients wearing cooling vests, and these are like neoprene, very subtle things you can wear under a shirt. I have teenagers that wear them, and you really can't tell the person's wearing one, and can drop their core body temperature by a degree or so, and they are much more effective in rehab. So I would put that out there as something to think about, because that might just get that extra little bit of rehab success, or make someone feel a little bit better. One of my patients was a pitcher, in Alabama, and in the hot summer days he loses some of his vision because he's previously had optic neuritis. And with a cooling vest and cooling down, he's been able to continue pitching. As you can appreciate, it's not a great idea to not be able to see when you're standing 60 feet from the ball. Yeah. So he was able to regain his sport activity by just staying a few degrees cooler.
And just to add a point to that is with the TM patients, sometimes if they're coming in, they're saying they're having a few days of symptoms that are quite similar to what they've had in the past, or maybe they're not sure if they're quite different. One of the things we typically do is look for evidence of infection, like looking at the urine, et cetera. Sometimes it's hard for people to detect urinary tract infection, especially if they have some degree of bladder dysfunction at baseline. Moving right along. Maybe it's best for Dr. Harder. Can you comment on the mood and cognitive changes that occur with TM, and what is the overarching theory about why this is happening?
Great question. This is one of my favorite topics. I don't think I've had the chance to introduce myself to the larger group. So I'm a neuropsychologist here in Dallas. I work with Dr. Greenberg and co-direct our Pediatric Demyelinating Diseases program. I was really surprised to find out that our kids with a spinal cord condition with TM actually do show cognitive difficulties. Because of these findings, we published a couple of years ago with the support of the TMA and a crowdfunding nonprofit called Counsel. We are just starting right now to enroll our first patients in a brain imaging study for patients with TM. We're going to get a closer look at the brain. We're going to use some non-traditional techniques to look at the connections in the brain and various other things. My neuroradiology colleagues are helping guide this process. We're hoping to get some answers about that. Right now, our theory, it's a little bit limited, but we believe that the CNS inflammation may be the culprit here and what is affecting our kids with TM in that area. With regard to mood, we have enough evidence to show, although the results are a little variable, but at a minimum I can say our patients with TM, NMO as well, and even ADEM would be considered to be at risk for both cognitive and mood-related changes. But it is important to note not all of our patients experience these symptoms, and our patients are encouraged to get assessments so that we can tailor interventions to address those. I'll make a shameless plug for my my afternoon breakout session. I'll be getting in depth into these topics, both cognition and mood, and what we can do to address these symptoms.
Very good. Thank you. Question for Dr. Levy. Is there any evidence or correlation between low levels of inflammation, i.e. subthreshold, and the symptom of fatigue in NMO?
Fatigue is a very difficult question in NMO because there's so many causes of fatigue. For patients who have poor sleep related to their illness, who have to use extra energy just to walk, there are many different reasons for fatigue, and one of those could be low-lying inflammation. The thought of the immunological rationale for suppressing the immune system in NMO is that there are episodes of relapsing periods where the immune system attacks, and then we think the immune system goes into remission, where it basically quiets down before the next attack. We don't tend to think of NMO as having a sort of smoldering inflammation. Having said that, we've seen a few patients who've had attacks that don't quite go away, and then as soon as you take back the steroids, the inflammation comes right back in the same spot. And certainly those patients have had smoldering inflammation. But generally, as a cause of fatigue, we don't tend to think of that as being due to smoldering inflammation. It could be due to medications, sleep, infections. There are at least a dozen other causes of fatigue in our NMO population, but probably not smoldering inflammation.
And maybe if I can extend that question a little bit, maybe for Dr. Becker in terms of rehabilitation, because it's probably a question he gets quite frequently. With TM patients and having problems with fatigue, how do you counsel your patients?
So as Dr. Nevi just said, I mean, we have to figure out first, what is probably the main cause of your fatigue. And so we address pretty much all the different individual levels, where we look at, Dr. Harder said, we look at mood, depression can cause severe fatigue. We look at medications. Are medications doing those things? How is your sleep? Having poor sleep pattern will cause a lot of fatigue. And a couple other hosts of problems. So we figure out first what it is. So if we can't come up with a good cause, then obviously we have to adapt in rehabilitation with that fatigue issue. And I spoke to somebody earlier on the break who said, every time I start exercising, my fatigue gets bad, I can't do anything else. And that's what I was trying to persuade people not to do after they leave today, because I said you should go exercise. You go out and just overdo it, and then for the next 3 days you're going to be laying in bed because you can't get out. So in rehab, what we do, we start slow, especially if you haven't done anything in a while. So you have to sort of start a light exercise program and then slowly start escalating it. If you can't do it on land, probably some people who know me know that I love the water for therapy. So if you can maybe start with an aquatics program, and it doesn't even have to be with a physical therapist. I mean, you can even start to look at the Y, the local around the corner. There's generally a personal trainer that will work with you. If you need more skilled therapy, then of course I think you need the physical therapy evaluation. But water is a great place to get started. The deeper you are in the water, for example, for walking, the more buoyancy you have, and the less impact and weight you need on your legs. And as you sort of get better, get more shallow and shallow water, you put more and more impact on, and at some point you sort of evolve from the water. We're in Texas, right? Careful. But then to graduate from the water towards land therapy, and there you can slowly more and more escalate your therapy there, and it will generally help with fatigue. So I warn people from the spiral, because you get more fatigue, you do less exercise, and then because you less exercise, you get more fatigue, and it goes down. But the same way, you sort of have to work your way back out. You do more exercise, manage the fatigue better, and overall you will win this.
I think I'll make a couple other comments on fatigue. There's fatigue at the cell level. I mean, our cells make energy, and that's your mitochondria. And so healthy mitochondria are promoted by exercise. So if you actually look at the mitochondrial content in muscle of people who are exercisers and non-exercisers is different. You change your mitochondrial content by exercise. There's a really neat study looking at identical twins, one of whom always won her race, beating her sister out. They were on the Canadian Olympic team, and they're identical twins. And when you looked at a muscle biopsy, the twin that always won had just a little bit of better mitochondrial function than her co-twin. I don't know about her psychology. I'm guessing that was interesting. But so you can make your muscles and presumably other cells more efficient and therefore less fatigable by doing appropriate exercise. I would think that's important. Obesity is also a risk factor for fatigue. So even obesity is at the extreme end, or even just being a little overweight, you have a lot of inflammatory cells in adipose tissue. So being leaner and eating a healthier diet and having a better body mass index reduces fatigue. Ask anybody who's lost 25 pounds over an appropriate period of time with a healthy weight loss and exercise program, without having any comorbid health condition. They will tell you one of the things they notice is they're more efficient at work, they're more efficient at school, they are less tired. So I think body mass index is something something you can do.
Thank you very much. Moving right along for Dr. Ming. In the UK, are acute therapy options such as steroids, IVIG, and plasma exchange as widely available or used in the same manner or frequency as they are in the US? Is that known or not?
I'm not sure I can comment on the US, but IVIG and steroids are used in children pretty commonly in the UK, but it's very much because we actually find it more difficult to access plasma exchange, and I think that allows us, or that actually affords us using IVIG sooner. But I gather, having been here, that there is a big drive to get plasma exchange used here pretty much sooner than there. And if given the choice, I probably would want to use plasma exchange in the correct context. But it's because we can't that we explore the possibility of IVIG. And as you know, we're currently running a clinical trial whereby patients with myelitis or transverse myelitis are randomized to getting additional IVIG in addition to standard therapy, which is steroids. And that's within 5 days of the diagnosis. So we're very keen to get our physicians making the diagnosis as early as possible.
And I'd like to add with the trial in the UK, it's very important. It's a question that's been asked by a lot of people that's been very difficult to answer in terms of acute therapy. What is the best acute therapy for TM? It's a question for, I guess, anyone who wants to answer. How do we convince our physicians that improvement can occur beyond 6 months post-attack?
I think we get that question all the time, and I don't think you have to convince your physician. As long as I can convince you that you know, and then you show it to your physician, then they will learn. Because you only have to see it once or twice in your career, and then you say, okay, you know what? I remember this patient who I saw that was like 5, 10 years out from the injury. They got better. So I think as long as I can put this into your heads that the recovery from these kind of injuries never stops. So your body will continuously repair. The question usually is, once we stop rehabbing or once we stop doing something active for it, then we sort of freeze it in time. And as we age, we might even take a couple steps back. Teach your doctors.
Okay. I'm just trying to read the writing here. What research is being done on alternative pain therapies for TM or NMO?
So I think Dr. Newsom is probably around here. Is going to give a talk later on pain. I mean, I'm not sure. We're not doing any active research at our institution, but what we started using outside of the traditional medication approach, and I'm sure anybody here who has neuropathic pain or nerve pain, which is the most common pain that happens in myelitis, has probably gone through a lot of different medications that we call neuropathic pain medications. In many cases, people have difficulty tolerating higher doses, and therefore, can't get to the level where they get best possible pain control. One important concept for pain that I always advocate to my patients is that we probably won't get you pain-free. At least, I can make you pain-free, but you won't be awake. So, so we have to find that fine line where we give you. You're welcome. We have to find a fine line where you actually have adequate pain control that you can function, but you're still, awake enough to participate in the environment. And in some cases, we can't achieve that with medications. I mean, people just will be very miserable and can't get anywhere. And so one of made the biggest impact in our clinic was the advent of epidural stimulation. And I don't know if anybody has heard about this here, but when I referred earlier to Susan Harkimer's group in Louisville, Kentucky, who helped people sort of walk, that's the same type of stimulation. It is an electrostimulation device that's implanted right next to your spinal cord. And what it does, it prevents the pain signals that come from your lower limbs getting to your brain. So it sort of puts a little bit of an electrical block in between. The beauty of this technology is that it has no side effects in terms of there's no medication on board. It's really a stimuli that you use, and you have actually full control over this. In the past, and so you have to be very careful before you now run out and get epidural stimulators. In the past, many institutions used to use older ones where in order to get these things into your spinal column, they actually had to cut you open, do a laminectomy, and then put those paddles on. There was a big involved surgery, and once these things were in, A, you couldn't take them out again, and B, you could never have an MRI again. And especially in the conditions we're talking about, that's devastating. So over the past 2 years, the company Medtronic has developed percutaneous electrodes, so electrodes that can actually be placed right next to your spinal cord as an outpatient surgery, essentially. And if they don't work, well, you pull them out and you're done, and they're MRI safe, so you can actually still have your MRIs down the road. And the therapy itself is fairly widely available, at least amongst the neurosurgeons. I think that's
I would like to add a comment in parenthesis is pain management in myelitis and myelopathies is really very difficult and frequently a nightmare for both the patients, families, and the physician. I think that the best approach, and probably Dr. Newsom is going to comment later on these issues, is to develop a very good relationship with somebody who understands pain management. The new technologies are very good, but I think that it's important to follow a stepwise approach. Don't jump right away to dural stimulators. That's not the right approach. The approach is just to build up, basically with medication, therapy, a good protection for pain, and be able to control the pain. If there is no other option, you may go to what Dr. Becker is explaining now. Unfortunately, in myelopathies in general, you also need to put in consideration what was the cause of the myelopathy. Because if the myelopathy is relapsing remitting myelopathy, all of these devices probably are not going to be helpful. Particularly, for example, in patients with NMO, if you have the potential for a relapse or other type of immunological problems, this type of intervention in some way may be not necessarily helpful. So the most important approach is to develop a very good relationship with somebody who understands pain, and I think that will be, I mean, the research on pain is still going on, and we don't have a magic bullet for pain management, unfortunately, but the only approach is just be cautious and take the best step.
When you take the question one.
I'm sorry, I'm just gonna move it along because I only got 5 more minutes, and I'm trying to squeeze in as many questions as we can. And for anyone who don't get to your question, please feel free to approach one of the providers here for some input. For Dr. Schreiner, do we expect to see any? Do we or you expect to see any surge in the number of AFM diagnoses this season?
Okay, great question. So we were waiting and cautious and apprehensive and uncertain whether or not there would be additional cases this year like there were last. And we're now most of the way through the period that was when patients were presenting last year, and I'm excited to say that we have not seen the surge that we had last year. Now, the CDC has reported to me as of last week they have about 3 cases that they are investigating in the country that could be AFM for this season, but that it remains to be confirmed. Interestingly, we have also not seen the enterovirus D68 this year circulating, causing respiratory illness or anything else. So thankfully, I can say that it does not seem like we are going to experience anything close to what we did last year.
And I got just one more question. I'm going to give this to Dr. Greenberg, even though he's hiding back there. Where are we on being able to track the incidences of TM nationally and globally?
I can speak loudly. I know we're being recorded. So there are 3 things in the works. Okay. Thank you. So first off, in terms of tracking, because we really don't have a great sense of the incidence or the natural history of what happens to patients, a group of centers got together, many of them here, and put in a grant 2 years ago to an organization called PCORI, which is the Patient-Centered Outcomes Research Institute. Part of the Affordable Care Act that went into place was many billions of dollars of funding into an independent agency. So it's funded by the federal government, but it's a standalone group separate from the NIH. To support research that focused from the patient's perspective about outcomes and epidemiology and new ways to tackle problems. A consortium of us put in for a PCORI grant and were awarded the first ever federal funding for a transverse myelitis directed project. So this is a pediatric TM project looking at North America and the United States, looking at the outcomes from children who have had transverse myelitis, and that's an ongoing study. In terms of being able to get a sense of what the true incidence is, It's actually a very difficult study to do. As Dr. Schreiner has referenced the CDC multiple times in the discussion with acute class and myelitis, this condition, myelitis of any kind, is still not a mandatory reportable disease in the United States. So there is no way to get a full sense of how many cases happen per year and what types. We are in talks right now with the TMA about 2 potential options to try and get a better sense as to what the frequency year to year of TM is. So hopefully at the next symposium we'll report the launch of those projects, but as we live and breathe right now, it's a very hard number to get at. And as you've heard today, and Brian's comments earlier about transverse myelitis, I think were dead on and loop to our meeting yesterday. For everyone here who carries the diagnosis of transverse myelitis, there are probably at least 3 different to 5 different patterns or underlying conditions. So part of what we have to do is refine our definition so that when we get a phone call that a case of, quote, TM has occurred, we're all speaking the same language. Because right now when people come to my clinic with a diagnosis of TM, I'm sure this is similar for all the practitioners here, we never know what we're going to get. You may leave with a diagnosis of TM, or you may leave with a different diagnosis because there is such heterogeneity. So unfortunately, we're a long way off from having that number, but working to get there.
Thank you very much, Dr. Greenberg, and thank you to everyone on our panel. It's a very distinguished panel here. And I'd also like to say thank you to the audience members. They're tremendous questions. Again, I apologize if I didn't get to your question, so please don't hesitate to approach one of the other providers to discuss that particular question. But also, we have panels this afternoon, some of which I think may answer at least some, if not most, of these remaining questions. So thank you very much, and thank you to the panel.